Good afternoon, everyone, and you are very welcome to this, our final episode in this season of QPS TalkTime for 2024. And we have maybe saved the best to last. For the last session of this year, we are looking forward into 2025. And today's topic is what's new for VTE quality and patient safety in 2025. And please do follow us on all the usual platforms on Twitter, X, and YouTube, and on LinkedIn. That's where you'll find us. And you can find all the previous talk times as well on our YouTube channel. Just to be aware, these are some resources for the Patient Safety Act. So the QR codes there will take you to some very useful resources, or you can find them on the QPS websites. My Health, My Voice, which has been developed to help patients and families get more out of their consultation. There are some resources available for that, and it's now available in Irish Sign Language, so you can see that there. The Walk and Talk Improvement Podcast, again, we'd encourage people to have a listen to the new episode there with Anne Gallen. There are many other episodes there that if you're looking for something to do over your Christmas holidays to stop you getting too bored when you're going for your Christmas walks, you can plug into Walk and Talk Improvement and listen to some of the great episodes there. Want to always also just flag up the QPS network. This is our new quality improvement and patient safety network that is coming together, and want to highlight again through the QR code. There are some webinars that will happen in. We've already had one, but we're going to have some further ones in January. There are some dates there: 13th of January, Introduction to NOCA, and then Human Factors. So I think keep abreast of that, and please do participate. And I'm going to hand over really to my co-chair today, Fionnuala and Áinle. And Fionnuala, it's a pleasure to see you. And I'm going to be in the background helping out and maybe facilitating some of the discussion later. But I'm going to hand over to you now to introduce our panel and today's session. Thanks, Fionnuala.
Thank you so much, John. You're all very, very welcome today. And thank you for already suggesting some answers to the question we posed in the chat. And please continue to do so. It's an absolute honour, first of all, to welcome to our panel today a very special person, Melanie Cleary Sheehan. Melanie has joined us today to inspire us to do better, and is going to tell us the story of her daughter, her beloved Eve, who tragically died due to pulmonary embolism in Ireland a couple of years ago. We also welcome very specially Dr. John Moriarty, who has joined at a very early hour of the morning from LA, where he is a specialist and professor in cardiovascular and interventional radiology, and an absolute global leader, the global leader in advances in pulmonary embolism care at UCLA. He also serves as the chairperson of the Pulmonary Embolism Response Team Consortium, which is where we aim to be here in Ireland, so that we can do better similarly for our patients. We're also thrilled to be joined by the amazing Anne-Marie O'Neill, who's been a stalwart supporter of the work we do here in Ireland, of the VTE movement from grassroots level for at least the last 10 years. Anne-Marie, isn't that right? Anne-Marie founded the patient organisation Thrombosis Ireland, and is a PE survivor herself, and provides support to innumerable Irish people who have experienced thrombosis within their families, or who have personally experienced thrombosis over their lives. And finally, last but certainly not least, my amazing colleague, Nóirín Bannon. Nóirín is one of the most phenomenal change leaders I have ever had the pleasure of working with, and she is a programme manager in the HSE Dublin and South East region, having previously served as programme manager for Ireland East. And you'll be very excited to see what is possible through excellent QI here in Ireland, and how this is scalable to a national level. And it will be, I promise you, an exciting 2025 for the VTE programme. So without further ado, I will hand over now to Melanie.
Hi everyone, thanks for having me today. It's a pleasure to be here. I'll start by telling you a bit about our wonderful Eve. Eve was 21. She lived life to the fullest. She had a full-time job. She actually worked in a shoe shop, which was fitting. She was a manager there. She loved her shoes. She loved collecting them, putting them away and not wearing them. She was just full of life and full of love. On the 19th of July 2019, Eve had a fall coming towards her car. This was quite a bad fall where her left leg actually went right under her and she landed fully on her right leg. And we knew it was a bad fall because she was kind of crying, you know, she was totally winded, not able to get up. So we brought her to UHL. First, we actually brought her home to get her changed because she was soaked. And she was triaged at 10 to 10 that evening. Eve had an x-ray following morning at around 5:30. And there was so much swelling there, they actually couldn't see if there was anything on the x-ray or not. So she went on to have a scan at 11:30 the morning of the 20th. He was actually on a trolley for 17 hours in a corridor because there was no beds available at the time. So at around 3:30 that afternoon, she was moved to a ward. The nurses expressed great concern about her calf because during the night of the 20th, she'd actually started to complain of severe hot pain in the back of her leg, and we could see that her leg was a really, really vicious red colour, and she was also complaining of pins and needles. So at around 8:30 on the evening of the 20th, Eve was told her scan was clear, she could go home and rest. So she had actually argued it herself and said, you know, my leg doesn't feel right. It feels numb and swollen, are you sure? So yeah, just go home, rest it, be fine in a few days. They found no break or anything. And a Lisfranc fracture was actually suspected, but they didn't find any fractures. So we took her home, and everything appeared to be normal that evening, and she was in good spirits. She was, I would say she was more affectionate than normal. At around 11:15, she had said she was very tired, she wanted to go to bed. So she kind of bummed her way backwards up the stairs, and we asked her, did she want a hand? And she had said no, she was okay. So at around 11:45, our worst nightmare happened. Eve's boyfriend was staying at the time, and he screamed my name. And I knew by the scream this was not normal. So when I got to the stairs where he was sitting on the landing, she was a really deathly pale colour and her lips were blue. And I remember him saying to me, she thinks she's having a panic attack or something. But I knew there was like a line of gel on her little forehead, and I knew that, you know, she was really, really unwell. Barry came up the stairs, my husband, and by my luck alone, he ran back to get his phone to ring an ambulance. He came back up and Eve had what I thought was a fit. It wasn't actually a fit, it was a heart attack. And we switched, I took the phone off him and he started doing CPR. And I remember thinking in my head, you know, why is he doing CPR? Why is he thumping her chest? And Eve actually regained consciousness the first time and was able to kind of sit forward and, you know, talk to us. I remember my youngest child coming out and I was trying to, you know, shield her from it. And she told Eve she loved her and everything would be okay. And I asked her to go back to bed, and the ambulance had arrived at this point. And they started working on Eve. And I remember the two ambulance crew looking at each other and saying, clot. Eve was lying on our stairs and they asked me to come back over, that she'd something to tell me. Eve's last words to me were, I'm so sorry, ma'am. She was brought to the hospital where they worked on her a fantastic Christmas tree.
Yeah.
To 1:50 a.m. and Eve unfortunately didn't make it, and it was in her post-mortem results we found that Eve had clots everywhere, DVT.
Yeah.
That travelled through her kidneys, her spleen, her heart and her lungs. Eve's risk factors would have been she was on the oral contraceptive pill for 2 years. She had a high BMI. She had a fall, a lower limb injury, and she was immobile.
Yeah.
And thank you all for listening.
Melanie, thank you. Thank you so much for again sharing Eve's story. I can tell how hard this is for you, and just know how much every single one of us appreciates what you're doing in her memory, in her legacy. She's so beautiful, and she still, you know, means so much to all of us. Melanie is working, for those of you who don't know, Melanie is actually working with us in the National VTE programme to develop, we're very honoured to call it Eve's Protocol, which will be a national guideline that will be released very early in 2025 in Eve's memory, and will be, you know, a piece of work that will ensure that through the work of each group, each hospital, each clinician, each nurse, everybody involved in the care of people with VTE, that this does not happen again, and that we have a very clear evidence-based protocol. Melanie, thank you for sharing beautiful Eve's story, for being with us today.
Thank you.
You're incredible. You're incredible. And for continuing to work with us. It just cannot be easy.
Thank you so much.
Melanie, I'm going to pause and ask if anybody on the panel would like to ask you anything or add to what you... Anne-Marie, thank you.
Thank you so much for sharing, Melanie. I suppose Melanie's story really highlights how important it is to risk assess every patient that comes through the door of the hospital. Because had she been risk assessed, as Melanie shared, she had quite a number of risk factors and would really qualify for some sort of prophylaxis. And had she received it, she may still be here today. So that's really that's one of our main messages when it comes to VTE patient safety. Like a 3-minute questionnaire to figure out if somebody is at higher risk and would need some intervention. So that's what we ask anybody listening today, to be really conscious of that with all of your patients, because, Eve should be here, and that's the tragedy of it. But thank you, Melanie. It's so hard for you to share that story over and over to get that message across, but it's powerful, and just thank you.
Thanks, I think no matter how many times I talk about her, I still get upset. I'm 5 years on, and
It's understandable. It's understandable.
Yeah, she will always be part of your life and our lives now, Melanie. So thank you for allowing her to be part of what inspires us to do better. Yeah, you're amazing. And just to say, for those of you who don't know, Melanie was actually the recipient of the overall VTE and Thrombosis Ireland Warrior Award in 2024, which was awarded to her in person on the 5th of October. Isn't that right, Anne-Marie? By Anne-Marie.
She's our national champion.
National champion. So I'm going to very appropriately now invite my wonderful colleague, Nóirín Bannon, to speak. And Melanie, you'll be so inspired by listening to Nóirín, because under her leadership, already in one part of the country, strategic measures have been taken to ensure that very, very clearly across every hospital, risk factors are caught early, and that audit measures are put in place to ensure that we never miss an opportunity to save a life. What Nóirín and the team have achieved is truly powerful and will be scaled up nationally during 2025 and beyond. So thank you, Nóirín, over to you.
Thanks a million, guys, and thanks a million for that introduction. So I'm going to immediately give you a whistle-stop tour of some of the initiatives we have started in HSE Dublin and South East, and our plans for 2025. But just to give you some background, we were originally the Ireland East Hospital Group. We were the largest hospital group, and that encompasses the Model 4, Model 3, Model 2 hospitals. So we initiated VTE engagement across all of those hospitals with a focus on progressing quality initiatives, starting probably around 8 years ago. In the last few months, we've been reconfigured into health regions, and that's now called HSE Dublin and South East. So the existing structure is what would have been traditionally known as the Ireland East Hospital Group, Community Healthcare East and South East Community Healthcare. And so we're now reconfigured into 3 new integrated healthcare areas. So these new integrated healthcare areas will further integrate the delivery of hospital and community services at local level. So these areas are now divided into HSE Carlow, Kilkenny and Tipperary South, HSE Waterford and Wexford, and HSE Dublin South and Wicklow. So the reason I'm giving you this introduction is just to explain to you that we've moved from Model 4, Model 3, Model 2, and now we've expanded out into the communities and included additional hospitals and lost some along the way. So we've Waterford and Wexford, East Wicklow, South Tipperary, South East Dublin, Kilkenny and Carlow, where we'll be managing and delivering public health and social care services. And our services now include acute hospitals, primary care services, community care, social care services, public and private providers, voluntary sectors and the National Ambulance Services and health and social care professionals. Suffice to say, there's almost 1 million people living here. So without further ado, I'm going to go straight on to giving you insights to our initiatives, striving for VTE excellence. And given that we've come from a hospital-based initiatives, now you can see from the previous 2 slides, we can broaden out to include the community and all of those other services as referenced in the previous slide. We wouldn't have been able to do any of the work to date without our VTE Service Review Group under the chairmanship of Dr. Barry Cavan, and also our membership includes the CEO of Thrombosis Ireland, Anne-Marie, and also we have administrative, clinicians and pharmacy nominees who have all been so proactive. We've had a shared purpose over the last number of years, very, very patient-centred, engaged and consulted with each other, shared, provided information, gave feedback, and I suppose also did change impact analysis. So if we initiated any things I'm going to show you later on, we also then reviewed, did they work, and looked at all times of adding value. Now under the new structure, this group reports and is accountable to the HSE Dublin and South East Clinical Director, progresses and supports VTE initiatives, and you know, I suppose I'd love to make sure you all get the message that it's very innovative, and wherever possible, we remove barriers. And our membership, as I've outlined, are proactive and diverse. We are the only region to have an activity dashboard view, so we can see VTE cases, all based on HYPE data. They're VTE accumulated, prior to hospital, and those that were acquired in hospital, and all pulmonary embolisms. So all of that data is available to our leads in each of the sites, our quality team, ourselves, and anyone who wants to view or interrogate this data. Traditionally, and now that we have this data, the activity insights aided us to be able to publish papers, because up to that point, we didn't have stats on VTE figures for Ireland. So we've now published papers out there, and you know, it's really important. Data, it forms the basis of all change management. So without further ado, the next slide highlights the Stop the Clot. We went out in 2019 with a road show. We did 6 weeks over 11 hospitals, covering the community and hospitals. Lower deck had upper deck, all different information leaflets. It was a phenomenal success, and no doubt Anne-Marie will allude to it too in her presentation. But just to say, that was what got us all invigorated and behind the initiatives that followed. Because we now had the data, then we were able to say we need to raise awareness, and we went out with Stop the Clot Roadshow in 2019. Then we said, it was spoken about earlier about having a VTE risk assessment. Anne-Marie mentioned it, and we knew the importance of this, so we went out to EU tender. We procured an app and we made it available to our sites free of charge. It's a very fast downloadable app. with questions that have been pre-agreed by our clinicians. We also have a comprehensive dashboard view that each of the site leads can view, and our leads at strategic and local level. We look at activities and trend lines, and as I said, it's then a monthly automated email goes to each of the key stakeholders, including the CEO and general managers, in relation to performance of the sites. And updates to the app, we've evolved the app significantly over the last few years and at no additional cost, so it's been value for money. The views on the Meg app, users have access to the recorded training sessions, so they can be explained to them how to use and upload the VTE risk assessment forms correctly. And our trajectory in the assessments being done has just increased, and we've about 7,000 VTE risk assessments uploaded to date. So we're very proud of the Meg app, and it is something that we would like to see rolled out nationally. The next initiative we got involved in was the pre-hospital side of the house. We wanted to know the understanding of the pre-hospital National Ambulance Service and Dublin Fire Brigade. So we reached out to our colleagues in the National Ambulance Service, and we carried out surveys in relation to their awareness. And out of this survey, we identified the need for a VTE awareness video. And then after we made the awareness video, we went back and did a repeat survey to again see what knowledge there was among this cohort. So just to acknowledge the work of our National Ambulance Service colleagues, our Dublin Fire Brigade colleagues, and Thrombosis Ireland, and obviously our own team, and getting that initiative up and running. And out of it then we've been able to have 2 abstracts that have been presented in Mainz in Germany, and also we got an invite to our first inaugural invite to the Pre-Hospital Emergency Care Council just there in November. So the video, I know Chris is going to share the QR code and the link that people can view the awareness video, and also I would appreciate if you could take the time, it's about 8 minutes long, to view the video and circulate it within your own sites or among your colleagues, because it's a really important, powerful video, especially that of the patient's experience. The next thing we were involved in was wider awareness initiatives. We're members of the National VTE Programme and Clinical Advisory Group. Proof of concept we carried out in relation to Thrombosis Ireland blood clot leaflets in all the sites, and worked closely with Anne-Marie on giving her feedback and aiding translation into all the different languages. We obviously promote all of the alert cards, QR posters, exemplar awards, World Thrombosis Day event kits. So all these things are very important in ensuring that there's ongoing awareness, and our user group meets bi-monthly, and in between all the workflows are assigned, and each person then reports back at the meetings. Our focus for 2025 is to support the rollout of VTE diagnosis and immediate treatment, which is the EVES protocol as referenced by Dr. Fionnuala and Áinle. Continue to fund and empower sites to use and increase VTE audits. And within our health region is to assist Tipperary University Hospital roll out the app and roll out in a phased approach in University Hospital Waterford. And again, we're going to continue our focus to advocate for VTE activity views for the health region. So the dashboard views we have, we want to now make that available to all our health region colleagues, both in the community and in the hospitals and those new hospitals, and continue proactive participation on national groups, raise VTE awareness broadly, and progress awareness with our colleagues now that we've started work with NAS TFB and the Pre-Hospital Emergency Council. And that is, in summary, my presentation. Thanks a million, everybody.
Wow, Nóirín, you know, walking around on call in various hospitals in IHG, we can see the impact of all of these incredible measures every single day at grassroots level. But to see it all presented by you and it was a stop tour actually stops you in your tracks. Congratulations to you and the entire team. And can I ask you a question, Nóirín? You've achieved so much with the group, but who may be helpful to include on a VTE hospital working group? Recognizing that it changes from hospital to hospital, but in general, Nóirín.
Definitely, I would say having your clinicians, your pharmacy, your data analytics, if you can, administrative. So it's having a diversity on it, and also if you can have absolutely a patient advocate, because we've absolutely reaped the rewards of having a patient advocate. I know it's not possible in every site, but if it is, it would be great to have that patient voice always there, or a relative. But I would say administratively, because they're the ones who can raise the awareness around the different outpatient ward areas, and then the clinicians obviously have an orthopedic oncology if you can, and then obviously it's pharmaceutical representation, and obviously hematology to the fore.
Thank you. And, you know, hearing Melanie's story just brings it back home to every single one of us. We have not got a minute to lose. We must scale up these initiatives nationally. And there is no excuse not to.
And Fionnuala,
Thank you.
if you hear what Melanie said there about the clot, when the ambulance driver said clot, and even that was part of what we were trying to make sure everyone sees that. And Melanie, thanks a million. I know that was very emotional, that what you had to talk through, just powerfully impactful. But even the way you said the ambulance man said clot, that's what we're trying to do. The paramedics and advanced paramedics is continuing to raise and broaden that awareness.
Yeah, they were impressive. Thank you so much, Nóirín. And kudos to you for all you've achieved and for your leadership. I would love to invite now to the stage, to the virtual stage, Professor John Moriarty. Are you there, John?
Yeah, it's a pleasure to be with you and to get the chance to hear all the incredible advances that have been made, to be inspired by Eve's story, and to get the chance then to share some of the things that are available now within Ireland to treat those sickest of patients, so that hopefully, while prevention is always going to be number one, and using that risk assessment tool to make sure that we get ahead of such a drastic problem like advanced PE or VTE, but that if it does occur, we now know that there are ways that we can treat these sickest of patients. So my role over the next few minutes that we have together is to run over some of the kind of newest things that are available, so that everyone can be aware of what is available, not just now for our patients, but is hopefully, with the processes excuse me, that are being put in place, going to be rapidly available to people regardless of where you are within the country and within the health system. As I said, my goals over the next few minutes, I'm going to run over what are the basics of severe pulmonary embolism, severe PE, and give a little bit of a flavor as to why this is such a healthcare emergency and why we want to make sure that we have the processes put in there. Talk a bit about what devices are out there, because some of these are quite new, and if you've been involved in the area for a while, you'll find that these are quite different to what we used to have, and therefore the thinking about where the resources need to go, I think, may have to change a little bit. And then finally, just give some pointers as to, if you're interested in this area, if you feel that this is important for you, for your patients, for the people you serve, for the teams you're part of, how do you get involved? And hopefully I'll answer those questions. Just briefly, one thing to bear in mind is that, as Dr. Áinle was saying, I am the president of the PER Consortium. I'll say this a few times. This is an international gathering of physicians, patients, pharmacists, and hospital administrators who want to make sure that this terrible occurrence, that, as you heard with Eve's story, that this is as limited as possible, that we want to prevent this from happening, and I really encourage you to join this. All right, so as we were hearing, acute PE, it's incredibly common, it's incredibly mortal if it does occur, and we are more and more recognizing that there are effects that are immediate, and we heard the terrible events earlier of where someone can have an acute cardiac arrest because of pulmonary embolism, but that we are becoming more aware that even in people who survive, they can have problems such as shortness of breath or lack of energy and inability to return to their normal work or life, that can go on for significant periods of time after their pulmonary embolism. So we want to make sure that we're treating all aspects of PE, preventing it occurring, treating the immediate risk, and then managing those long-term complications that can occur. And it's important to remember that PE accounts for in the range of 10 to 15% of all in-hospital deaths. So it's the most common preventable cause of an in-hospital death. So that activities that prevent it happening, such as the risk assessment tool you heard about, really have a huge impact across the system. It's also important to remember that it's very dangerous, that with an acute heart attack, an acute MI, the average death rate is about 4% in the first 3 months. And we are very happy to make sure that we put resources into acute MI with national strategies of transport of patients to to centers of excellence, of making sure that all the processes are put together. We have to do the same for PE because the case fatality rate is up to 5 times higher. And so we want to make sure that all those processes are put together to help our patients now and into the future. So there are 3 different types of PE. They come by different names, whether it's high risk, intermediate risk, or low risk, but effectively, the difference between them is that people who are in the worst group of PE, those are the group I'm going to be talking about today, the massive PE or high risk PE, they have a very high mortality, and somewhere between a quarter to a half of these patients are going to die, unfortunately. So these are the patients who are at the biggest risk, and therefore the treatment strategy for them is going to be different to someone who has a smaller PE, who has a less chance of dying and perhaps can be managed in the outpatient facilities. So you will see that the goals of treatment are different. And what I'm going to be talking about today are rescue. In other words, what can we do for those sickest of patients to kind of bring them back from the brink and make sure that we give them the best fighting chance of moving on with their life. So this is what we're dealing with. Here we can see a large blood clot. These blood clots tend to be in the range of many centimeters, 10 to 15 centimeters, sometimes longer. They are big clots that we're talking about forming in the legs or in the veins of the pelvis that then move up into the heart and from there into the lungs. And so to remove a big blood clot, you typically need something that's quite strong, whether it's a very strong medication, such as a clot-busting agent like TPA, or a device or surgery that can remove large volumes of clot. To compare this to stroke or to an MI, to heart attack, you're talking about very small clots in those areas, very large clots in pulmonary embolism. So what do we know? We know that the clot-busting drugs work, that if you're able to get a clot-busting drug in the correct time, in the correct patient, that you can really help mortality. And we see here a treatment effect that is very rarely seen in medicine, where we see a very marked drop in mortality with the correct medication. And so the first thing to say is I'm going to be talking about fancy devices and things that can be used to remove clots, but if you have someone who has a high risk or massive pulmonary embolism, the TPA, the clot-busting drug, that is the #1 first stop. And almost every hospital around the world should have availability of this drug to be able to prevent acute mortality and acute deterioration. And certainly in Ireland, this is the #1 stop for most of our patients who are presenting in extremis. But the problem with this clot-busting drug is that it can cause bleeding. And this bleeding can occur in up to 1/5 of all patients. 20% will have what is called major bleeding. And the patients who we really worry about are patients where it bleeds into the brain. And so in 3% of all patients who get this vital clot-busting drug, you're going to see a bleed into the brain, an acute stroke, a hemorrhage, and this can obviously be a terrible event. And so because of this acute bleeding into the brain, there are many patients who either are at high risk and therefore don't get the medication. And you can imagine someone who's had a fall, someone who's elderly, someone who's had a previous stroke or surgery being in that group, or indeed because of people's perceived feeling about this being a high risk medication, patients who should get it are not getting it. And so therefore we need to do better about giving them more options. So what are those options? The good news are that there are lots of different things that we can do. And this is pretty much plumbing. If you have a blockage in the blood vessels of the pulmonary arteries, the way that the blood from the heart gets to the oxygenated lung, if you have a blockage, we want to unblock it, and the plumber can come in and remove it by either sucking it out or by rotarooing it, by twisting devices to break it up and crack it open. And now we have dedicated devices so that our patients who are in extremis, who have a blockage of these blood vessels, can now have a very small little tube placed in through a vein over the hip, and then moved up through the heart and lungs, up into the area of the blockage, and have the blockage removed very fast. All of this is similar to what we do with stroke and with MI, but is now coming to PE, and therefore we hope going to be having the same improvement in results that we saw in those two areas. I'm going to quickly talk over some of these mechanisms just so that you get a feel for what is coming down the pipe to you. Here we can see a blood clot that's blocking the main blood vessels here. What we do is we come in, we pass a little tube from the vein over the hip, we deploy a device into the blood clot, and then as we are moving this device into the blood clot, we give a medication, this TPA, this drug. And because we're doing it directly into the blood clot, we are hopefully able to give the benefit of breaking the blood clots up without having the downside of that kind of bleeding into the brain risk. And this is available at many different sites within Ireland. It is performed by an interventional radiologist who's a doctor who works within the blood vessels. And so our goal with all the efforts that you heard is to make sure that this becomes well known, it becomes available in a rapid format, and that it is protocolized throughout the country. The other way that we can do it is that we can directly suck out the blood clot. So I'm going to use a few names here of different devices or different ways that we can do it. All of these are available within Ireland. And the good news is that these are designed to help patients who have no other options in some case. Maybe they've had surgery, maybe they've had a bleed into the brain before, a stroke before, and they're very effective. One of the things that can happen is that a blood clot can get caught within the heart. And this is a video of a patient who, a young person, 24 years old, who had a big blood clot within the heart. Here you can see it bouncing around. And what we're able to do is put up one of these large devices. And here you can see the blood clot being removed. So these are big foot-long clots that you can imagine being a terrible event where it blocks up, say, the heart or the pulmonary arteries and causes an acute deterioration, something similar to the awful stories we were hearing earlier on. And the good news is that now we're able to remove these blood clots quickly, easily. Patients do not have to go for open heart surgery, and their recovery tends to be very fast. So other examples here, these are dye tests that we do. This is not so much to highlight the actual techniques, but rather to show you what it involves. So here you can see that we're passing these tubes into the heart and lungs under X-ray guidance. Patients are awake, so that therefore they're able to tell you how they're feeling. They're able to tell you that they feel the chest pain or the shortness of breath be removed as we are moving these devices into the clot and directly sucking out the clot. And the real benefit of this is the speed, is that this is something that can happen fast and that we are able to remove, as you see here, large volumes of these clots, these big blood clots that previously would have been fatal, and we're able to do it very fast. And I'm not going to give much in the way of data, except to say that there are now trials coming on board which show a marked improvement in what we think the survival would have otherwise been. I say we think because we haven't definitively proved it yet, but we're moving towards that, I feel. And so here, an example, this trial, which looked at the highest risk population, these people who have that 25 to 65% expected mortality, 97% survival. Now, we can quibble about different parts of this, but this is a huge improvement to the majority of our patients and something that we really want to look at hard and making available within Ireland. Another example here, this is a device that the team in the Mater have a huge experience with and is now being used at multiple other sites within Ireland. Again, just so that you're familiar, called the Penumbra or Indigo device. And it's a device where here you could have this patient who has a blood clot within the lungs. Their heart is beginning to fail. That right side of the heart is dilating. And they also have developed a brain bleed because of some of the medication that had been given beforehand. So historically, this patient would have been very challenging to manage. Are you going to be able to use the medication that breaks up blood clots? Probably not. Are you going to be sending someone for open heart surgery with all of the problems that come with that? Probably not. What are the options? Well, the good news is we have some now. So if we go to the next slide, you'll be able to see here that we were able to pass this tube up, and this is what your lungs look like afterwards. We're able to open up all those blood vessels very quickly. And I remember this patient very well. This is from the Mater. And here you can see, I remember this patient who had crushing chest pain, shortness of breath, and we removed the blood clot, and immediately within seconds, they sat up feeling much better. So it's very gratifying for everyone who's part of the team to be able to see these patients kind of pull back from the brink. And we remove all these blood clots, again, allowing us to hopefully improve these patients' survival in the short term, as well as their ability to get back to their normal life afterwards. So, as I said, we are coming into the space here that is a trodden path, that people 2 decades ago, when cardiac care began to be protocolized and improved with various national plans, and then a decade ago when stroke, thrombectomy, removing blood clots with national plans throughout Ireland, to moving patients to high volume centres such as seen in Beaumont, they came about because of trials that showed real benefit. And now this is where pulmonary embolism, we're beginning to move in the same sort of pattern. And so over the course of the next very short time, over the course of the next few months to years, all of the trials that you see up here on the screen are going to result. And hopefully this is going to give experts in the field like Professor Áinle the ability to say to the individual patient in front of them, man, woman, young, old, acute, chronic, all these different things that are going to make each patient specific and different. What is the best thing for you, whether it's a medication, whether it's a device therapy, which device, all those kind of things. We're going to have more answers to that. Now, obviously, I've kind of thrown a lot of stuff out there. I do want to say that the good news is that there are many people working together to help patients with these problems, to help hospital systems put in place protocols to make sure that patients can be rapidly moved to the best people to deal with these. For those of you who are interested in this, I would suggest being part of PERT International, which is an international consortium throughout the world, including some centres in Ireland, of physicians, hospital administration, and hospital systems to try and make sure that this sort of disease that afflicts so many people is improved as well. And so to summarize, where are we right now in 24 as we move into 25? PE, super common. It is a lethal condition. The good news is there are multiple treatment options and more coming on board every day. And that PERT teams, this idea of working together with everybody, bringing their expertise, this is the main mechanism for patient selection and the way that we are going to hopefully improve outcomes into the future. So with that, I'll thank you very much. I'll leave this QR code in the chat then, so that if anyone is interested in becoming involved with this international grouping of people who want to improve patients' lives and outcomes, we'd be very happy to have you. With that, thank you very much.
Professor Moriarty, thank you so much. That was a stunning talk. And thank you also for your global leadership in showing us what excellence in quality and patient safety looks like and how it can be achieved using a systematic approach. I can see Anne-Marie has her hand up. Over to you, Anne-Marie.
Thank you so much, John. It's just fantastic to see all the research and to see what can be and what is happening. I suppose just to bring things right down to basics, we support patients all the time that have like post-thrombotic syndrome. They even after they survive their clot, they have like lifelong pain. And there's patients that have gone to you and had those clots removed. Like we had a 20-odd-year-old who had one leg was, you know, a lot bigger than the other. Her shoe size was different depending on her foot, like the post-thrombotic leg. And she couldn't wear a skirt. She felt like her life was completely destroyed and over. And just by removing, she had an immediate reaction to having that clot removed. Her leg went back to normal size and color. I know it's not 100% all the time, but to just for the clinicians out there to consider it as something rather than leaving people in pain. These options are available and they're fantastic and they work in many cases. So thank you for sharing that.
Thank you, Anne-Marie, and I'll say you're right. I think that that the results can be very good for the majority of our patients, but the most important thing is what you're doing, which is to get the word out. These are patients who frequently are shuttled around. They don't understand in a way that the benefits of different treatments, because the medical system hasn't spent as much time and effort on concentrating on VTE as perhaps on other conditions. And so doing what you and Thrombosis Ireland are doing by making sure that there's an awareness of the disease, of the problems that can happen, not just acutely, but chronically to patients, is the most important thing. And if people are able to speak up about their own disease, have their physicians make sure that their doctors are aware of that, and then on the flip side, making sure that the doctors know who the best people to refer to, that is all going to help massive amounts of people.
It's life-changing, John. You know, like, it really affects people's mental health to be left disabled. I mean, and that's, you know, they can't move on with their lives. So the fact that there's hope and that they can try another treatment, something different, they're not just being left. And you're right, a lot of patients feel like they're being thrown from Billy to Jack or just dropped. Once basically their 3 months is up and they're off the anticoagulation medication, in a lot of cases, people do feel like they've just been left. But I think it is changing, and I think it's wonderful that we're even raising awareness that there is other options that we can consider for patients. So thank you so much for the work that you do.
Thank you.
Thank you, John Moriarty. And I'm handing over now to Dr. John Fitzsimmons for the final wrap up and taking some questions. Oh, you're on mute, John.
Well done, everyone. That was really a tour de force, you know, and you know, the impact of this condition from Melanie and hearing about Eve's story, you know, the reason why we're all here today, and then all the great work that you're doing in terms of I suppose risk assessment and prevention, and then the treatment end of things. It's certainly very exciting for the year ahead, and well done. There's a couple of questions. One from Anne-Marie Kirwan here. Just, we welcome national VTE guidelines. Would that include a VTE risk assessment? Fionnuala, is that something you could answer?
Thank you. Thank you so much, Anne-Marie. Yeah, so Eve's protocol will be launched in Q1 2025 with much love and thanks to you, Melanie. So actually, the protocol that was developed many, many years ago by the group at the time, QID Directorate, with Ciara Kirk and Philip Crowley, that tool has been updated throughout COVID, and it was amazing actually how rapidly that brought in those new risk factors that were thrown at us during COVID. So actually, that tool is already available, Anne-Marie, but it will be, you know, in the Eve protocol also, because we felt it would be important to demonstrate the importance of having a risk assessment tool.
And that risk assessment tool is available online,
It is. It is, John. We'll get the link for you all.
Yeah, great. Okay, we can put that up afterwards. Another question there from Bridget Dundon. What hospitals in Ireland do the thrombectomies for pulmonary embolus? Is it only Model 4 hospitals?
Yeah, Bridget, thank you. There is a gap in Ireland right now in terms of what, as John has shown us, what true excellence looks like, and you know, centres that the PERT system has modelled what are called centres of excellence in pulmonary embolism care, and certainly the programme will be working hard to close that gap and to get to that point. That's as much as I can say at the moment. Do you have any comments, John Moriarty?
Thank you. I think you're right. There is a gap, that it is kind of an ad hoc sort of approach at the moment. The efforts that are ongoing by several people on this call to make sure that there are, for example, transfer protocols towards places where it can be done in the right time frame by people who do a lot of it, are going to be hugely important. And there's going to be a multi-step process, because nowhere is this is this working perfectly?
Okay.
But I think the most important things are awareness, thanks to events like this, and energy. And there is now huge energy towards improving PE care.
Thank you, John.
Great. And I think just another question from Bridget Dundon there again, which I think probably is on the back of that one. You know, any guidance when it is safe to mobilize a patient when being treated for a PE in hospital? Fionnuala?
Yeah, thank you, Bridget. There is sort of a long, unfortunately, dogma over the years that patients who are in hospital with pulmonary embolism shouldn't be mobilized, and that's of course the worst thing you can do. So once somebody's obviously safe and able to, you know, not able to kind of breathe comfortably and able to tolerate the pain, then we should be, as Anne-Marie always says, your recovery starts now. You're safe. You're get up, get moving. And that's exactly what inspired Anne-Marie's leadership. I think I'm right in saying that, Anne-Marie, isn't it, in terms of the recovery program, the amazing recovery program that will be the final part of Eve's protocol. Would you like to say a few words on that, Anne-Marie?
Yeah, so I think recovery starts once the anticoagulation is in place. So a couple of days probably once your anticoagulation is in place, and then you get moving. And it's important to, you know, get back to what you usually did and be gentle on yourself if you can't do it all straight away, but to build yourself up to at least an hour's walking or swimming or cycling every day. And I think the key from our experience is consistency. Encourage your patients to walk every day or swim, you know, walk, swim or cycle every day for 7 days, just for an hour. Build it up, start slow and build it up to about an hour a day. And that's what will help the body recover and absorb those clots and get your recovery back. And then if you need John in the meantime, to remove it, if it's not getting any better, take action and do it early rather than leaving it for years. You know, inquire about it. Phone Thrombosis Ireland, we'll put you in touch with whoever you need to talk to, and hopefully get back to normal as quickly as possible.
Thank you so much, Anne-Marie. You're an absolute inspiration. And look, I just see a question there from Ali Bone. Just Ali, yes, absolutely. We were very honoured actually to include the IAEM guidelines that were really good in 2021, and we've amalgamated them into our current Eve protocol, which of course will include not just the awareness and prevention of VTE, but also the diagnosis and acute management and recovery. So diagnosis of and management of suspected DVT will be a major part at the centre of Eve's protocol, with great love to you and your family, Melanie, and everybody out there affected.
Well, thank you all. You know, I think that's a very hopeful message, and I think that's a nice way to finish up. And I want to thank everybody, especially Melanie and Anne-Marie for being here, Fionnuala, Nóirín, and John for getting up so early. Thank you very much.
Yeah.
And Fionnuala, you may want to just say goodbye there from everybody, and then we'll just finish out.
Thank you, John. Thank you to the phenomenal panel, to all of you for being here today. And really thank you to Melanie. We will never forget, Eve. We will never forget what happened to you and to your family. And it's a call to action to remind us to keep going, no matter what the struggles and the challenges in navigating the changes that are afoot over the next few months. We will do it, and we'll get Eve's protocol implemented across the country in her memory and in the memory of so many people who tragically, just like Eve, have lost their lives. And for those who have survived pulmonary embolism, to ensure that they live life to the full. Thank you.
Thanks, Fionnuala, and thank you for your leadership on all this.
Thank you.
So, folks, that's it for our series for 2024. Thank you for joining us and for being here, and I think for participating so much. We look forward to seeing you in the new year. We will be back in January, and we have a wonderful guest in January, Dr. Hardeep Singh, from Baylor in Texas, who it really is a world authority on the whole idea of diagnostic excellence, of improving diagnosis and reducing diagnostic error, while at the same time trying to reduce over-diagnosis and over-investigation. So join us for that. If you want to have a little prelude to that, we did a short podcast with Dr. Singh for the Walk and Talk Improvement series back earlier in the autumn on the back of Patient Safety, World Patient Safety Day. And I think you'll get a good sense of what Dr. Singh is going to talk about. And please do, if you're looking for something to do over the holidays, tune in to the Walk and Talk Improvement podcast or to previous episodes of QPS Talk Time. And I look forward to seeing everybody in January. Thank you very much.